This is a really neat question, and there are a few papers in literature that talk about this, and they kind of go back and forth to some degree. The big issue is that we know with historical or conventional immunosuppressant agents that patch testing probably is really not a great idea on those because you really could suppress the response and thus in other words, get some false negatives, important allergens. With dupilumab, we're not exactly sure which allergens might use the IL-4 and IL-13 pathway, and it may even vary from person to person. It's not maybe just that it's nickel, for example, or some particular, specific allergen like cocamidopropylbutane, but it may be in an individual, this pathway is the one that's sensitized. That being said, I think that pragmatically, we can say if a patient has atopic dermatitis and is doing well on dupilumab, except they're having some breakthroughs, and we suspect that there is a contact allergen that's playing a role. To me, we wrote a paper about this recently, this past year. We said we think it's very reasonable to do it because in that case, if the dupilumab is not enough to protect them from environmental exposure, it's very likely not enough to protect them from showing the sign when you do the patch testing on their back. And I've personally seen many patients patch test positive to a clinically relevant allergen while on dupilumab, and then we remove that and they do better. So I think this is a real thing, but we have to go with the caveat that we may be missing some things and we don't know all of the details. So it's kind of an interesting area, and I just try to do it with full disclosure to the patient, especially because I say usually we don't have to patch test somebody more than once in their life. Sometimes you do it again 5 or 10 years later, but it's not something you're doing a lot. This is a situation though where we may say if we don't find it, maybe later when you're off of dupilumab, we would try it again.